Good morning, good afternoon, good evening. We'll get started in just a minute. Thanks for your patience. Wonderful. Well, I think we'll go ahead and get started. So good morning, good afternoon, and good evening to everyone joining us from around the world. My name is Liz Colway, and I serve as Director of Global Community Engagement and Applied Learning at the Sabin Vaccine Institute. And it's my pleasure to welcome you to today's session in the Zero-Dose Learning webinar series entitled Getting It Right, Using Quality Data to Prioritize and Reach Zero-Dose in Under-Immunized Children. We're especially pleased to launch this new series in collaboration with and supported by Gavi, the Vaccine Alliance. This series represents the culmination of many months of thoughtful review and synthesis of existing materials on reaching zero-dose children. And we're excited today to share a particularly impactful set of strategies that have emerged from the process, and strategies that we believe can make a meaningful difference in reaching zero-dose in under-immunized children. If you're just joining us, we'd love to get to know you, so feel free to introduce yourselves in the chat and let us know who you are and where you're joining us from. And before we begin, I just have a few brief housekeeping notes. So the session is available in both English and French. To listen to your preferred language, we ask that you please select the appropriate interpretation channel from your Zoom menu bar. And likewise, you'll also be able to view the presentation in your preferred language, and you can toggle between screens at the top of your Zoom window. On the next slide, we just ask that you please mute yourself when not speaking to reduce any background noise. You're encouraged to engage with your peers and speakers using the chat feature. And then hopefully, if time permits, you can use the reactions button to raise your hand during the Q&A to voice over your questions. A few more reminders. Please note that all session materials, including the recording, slides, and additional resources, will be uploaded to the Zero-Dose Lessons in Action Learning group on the Boost Community platform by the end of this week, and will also be shared in a follow-up email. Now, for today's session, we'll have some welcoming remarks from the Gavi team, followed by an engaging moderated panel, and hopefully ample time for Q&A from the audience. And with that, I'm going to actually kick things over to Rita from the Gavi team, who's going to provide a bit of an overview of this series. So over to you, Rita. Thank you.
Thank you, Elizabeth. Good morning, good afternoon, and good evening, everyone, and welcome to this series. So Gavi, the Vaccine Alliance, as a learning organization, we are committed to turning insights into action and believing that learning is the engine of progress in immunization. We are working with Sabin to digest the amazing learnings that we have achieved with the Alliance partners during this cycle and use it to enable us to adapt strategies based on evidence and experience to share what works, what doesn't across countries and contexts, and to build systems that evolve with emerging challenges. So this is why we have mapped and reviewed over 140 resources developed with the Alliance. And it was interesting to note that more than 100 of those resources highlighted digital as key enablers to reach zero dose. Plus, they highlighted the importance of data quality in collection, use, and impact. So that's why today's session focused on the critical intersection of data and digital, with 48 Gavi-supported countries using the HIS2 as their health management information system, and over 10% of HSS budgets directed toward digital strengthening. This topic is both timely and foundational. So I hope you enjoyed the webinar. Thank you for joining us today, and definitely looking forward to hear your feedback. And with this, I conclude, and over to Daniel. Thank you.
Thank you very much, Rita, and good day, everyone. As introduced, my name is Daniel Yale. I'm the Senior Manager for Digital Health Information Systems at Gavi, and I'll be your moderator today. I'm particularly excited to welcome participants from across programs, ministries, and even frontline health workers to this call. I think just to set the stage, I would say that for us in the immunization space, we share the same reality, which is if we do not get the input right, then we cannot get the right course of action. So today we would spend some time looking into data quality and how it undermines the action that we need to take as far as coverage estimation, resource allocation, and at the end of the day, trust and confidence in our program is concerned. We will surface the challenges. We will see what is working, the very practical approaches. We would have three quick presentations, which will be followed by Q&A, because we really want to hear from you colleagues on this call. And we hope that the combination of the presentations as well as the Q&A will leave all the participants with knowledge as well as resources to be able to identify these gaps accurately and then plan to address them from a very relatable perspective, and also see a lot of evidence which we'll be sharing that has worked in different contexts and be able to adapt them. So we would start with the lightning presentations, and I would call on Ibrahim Dadari, who is the global lead, the urban immunization at UNICEF HQ, to take us through the first presentation, which is on the burden of data quality and programmatic implications. Over to you, Ibrahim.
Thank you, Daniel, and thank you, colleagues, Rita and colleagues. Good afternoon, good morning from wherever you're joining. Ibrahim Dadari here from Immunization Section UNICEF HQ. So basically, I will be giving this lightning discussion looking at the burden of data quality and the programmatic implications. So input equals output, right? So we're going to look at that. And see how that will impact our programming. Next slide, please. So what is data quality? Basically, data quality talks about looking at the various parameters of data from different perspectives. Data needs to have integrity, for instance, making sure that it's not manipulated. There has to be consistency, and we're going to see some of these inconsistencies, which is featuring from some of the work we're doing. Data has to be timely, and also has to be accurate. Basically, it should reflect the true situation of what is happening at the countries, because it has, as we said, it has programmatic implications, and it needs to be complete. For immunization data to be useful, it has to be of high quality. As if we have data of low quality, it's gonna negatively impact our programming. And when we talk about immunization data, we basically have two types of immunization data. The individual level data, basically, which looks at patient at individual level or client, as we say, looking at patient client identifiers, specific vaccine details at the individual level, the day the person received the vaccine. Issues like adverse events following immunization are looked at more at the individual level. But most oftenly, in the immunization space, we look at aggregate data. So this looks at the number of doses administered by antigen, for instance, the number of doses of penta vaccines or PCV or rota vaccines administered. It also looks at the stocks, inventory, the supply chain data. It also talks about, we're going to look at coverage rates, and that's very important, and dropouts. These are some of the things that we discuss often. But then the key, one of the most important aspects is the denominator of the data that we use, because that's what we use to compute our coverage, to calculate all the necessary parameters and decide where are we having zero-dose children or under-immunized and what action needs to be taken. Next slide, please. So we're going to look at some of the analysis through our AHEAD project that we did in Uganda. AHEAD is a project within UNICEF that looks at subnational analytics, trying to tease out the details of data. If you look at the first table up, you see it gives a picture in some instances of Penta 3 data more than much higher than Penta 1. As for those of you, or most of you, are conversant with the immunization schedule, we have the first dose of DPT containing vaccine, which is Penta, and then it's followed by the second dose and then the third dose of DPT or Penta vaccine. And typically what we see is that there is some dropouts along the line. Not all those that start the first dose of Penta will complete the second dose as well as the third dose. But usually the difference is marginal. We have an acceptable range of 10%. But if you look at, for instance, the first row, two row, admin 1, you see we have 1,364 Penta 1 doses, but then we have close to double, twice that as Penta 3. So the implication of this, it's telling us that we started with 1,300 kids getting Penta dose, but we ended up with almost twice that. So where did the children come from? So those are the kind of things that you look at in data that tells you that there's a problem. It may just be a programmatic or population movement, but when it's very substantial, it raises an alarm for us to look at. And you could see the same in West Nile, the same in West Nile, Arua City, West Nile, Terego district. So that's it. You see, the first dose of Penta is much, much lower than the third dose of Penta. And this is data that is aggregated to be reported globally, and then we use it to estimate coverage. When you look at the second table down, it looks at, you have very astronomical levels of Penta 1, but then low levels of Penta 3, right? Which is atypical also. As I said, we usually have a fair margin of 10% dropout between Penta 1 and Penta 3. Sometimes it goes to 20, 30%, where we say it's okay, but we can accept that, but it's not okay. Action needs to be taken. But when we have a situation where, for instance, in the first Leatonde district, for instance, you see 7,780 doses of Penta 1, and then 12 doses of Penta 3. This tells you that there is an issue. Maybe let me shut down my video. So the same you see with Wakizo district, 1,602, and then baby Penta 3, 979. So you could see the Penta 1 doses are multiple folds of your Penta 3 dose, which shouldn't be the case. So it's pointing to you that there is an issue with this data. Sorry, I had to switch off my video. Maybe my internet is not very strong. Next slide, please. So when you look at this is looking at outliers of vaccine doses administered. The same here, you could see, for instance, if you look at the trajectory of vaccines doses administered from like the previous months, from the first table is looking at April to December, month 4 to month 12, right? And you could see the trend in values. It's looking at, for instance, 14, 15, 14, 16. So that also links to the denominator or target population within that district or health facility, right? But then you come to where you see the areas highlighted in red, it jumps to 7,780. It's telling you that there's something wrong somewhere. If that facility has a target population of, let's say, 15 or 20, and then you're having values of vaccine doses administered to be 7,000, then there is definitely a problem. And these are some of the things that push our coverage figures or graphs to look to have significant outliers. The same thing happens with the second table. So let me just move. Next table, next slide, please. And another issue that we face often is missing data. So there's a difference between zero data and missing data, right? When you have zero data tells you that no one was vaccinated or no vaccine was administered. So it was actually reported, there's something recorded. But in missing data, it's blank. You don't know whether it's zero, it's one, it's 100. We don't know. Was it skipped erroneously by the recorder or what actually happened? And in that case, it's difficult to make any meaningful interpretation or extrapolation, and difficult to make programmatic decisions with those kind of data. We've tried severally in different places. You make some assumptions and say, okay, based on the trend, this is what maybe perhaps you can take a meaningful value of X or so numbers. For instance, in this case, you have in Gubara Health Center, where you have 10 doses of Penta 3, you could say maybe Penta 1 is 12, 13, 15, and then look at the previous history or something like that. But it has to be systematic the way we approach it. You don't just do it ad hocly. Next slide, please. So now we looked at this. So, and all these issues that we've highlighted in terms of data from the outliers that we see, for instance, missing data, you see also implausible relationships between different specific doses of antigens. That is what aggregates to form our administrative data and usually contributes to our official immunization data. And outdated census information, for instance, do not reflect current population dynamics. Usually, most countries, there are countries that had their last census in 1970, and we're still using projections from that population to estimate target population and use it to compute coverage. Definitely, we know that that's going to be out, it's going to be off. We see usually, we did some analysis we did recently. We have uniform population growth rates. Usually it's the national average that is applied during projections. But we know that different population groups and communities and regions have they have different growth rates. Sorry, I'll switch off again. They have different growth rates, and that should be, it's difficult to apply that, but then the fact that we apply a uniform growth rate poses a serious challenge. And also population movement, particularly in the areas of conflict where we have populations that are being displaced, either due to conflict, due to several other natural hazards, that could significantly alter the configuration in terms of data. Next slide, please. And this is, for instance, when you look at earlier, we had Toro as one of the districts, and this Kenjojo province or region, and with this Kenjojo district has that as is part of that Toro area. And when you look at, for instance, a Kasanda sub-region here, you could see the way it's spiked. Perhaps when you dig deeper at the subnational level, even go down to the district and even sub-district or even facility, you could be able to pin down where exactly the problem is. Otherwise, it affects the entire data itself at the district level, at the provincial level, or even the national level. And this can have implication, particularly when you have multiple of it. You have missing data here, you have significant outliers here, you have implausible relationships here. that poses significant challenges and to credibility of our immunization data. Next slide, please. So in terms of, there have been, just to say quickly, in terms of improving data quality, there's some steps that have been taken to do that, particularly disaggregating the data, looking down to where the issue is, and then addressing the specific problem at that point, because it's not, when you see outliers or data's looking weird, it's not all the subcomponents that probably have an issue, but usually it's a particular one or particular few that needs to be targeted. And then we jointly decide on an appropriate action and then clean the data to make it more useful. Next slide, please. How does poor quality data undermine programs? So one, program planning. If you have denominators that are inflated or underestimated, we've seen places where you have coverage figures as high as 300 or 400% for a particular district. It's telling you that probably if that happens consistently, then you have an issue with your denominator. But the challenge usually is the denominators are probably projections that did not account for some of those things like migration and population movement. You end up having those exorbitant coverage rates that mask and cover areas or underserved areas. So it's very critical when the denominators are inflated or overestimated. Then coverage estimation, of course, impacts your coverage estimation. You see 100%. You see there are some places where you have negative dropouts, some of it significantly large, that makes it difficult to make any meaningful programmatic decision with that. Resource allocation is impacted, of course. Usually, when we see areas with very high coverage, even though some of it might be due to denominator issues or poor coverage computed due to or data with different quality issues, we tend to prioritize those areas that seem apparently to look or have low coverage and high numbers of zero-dose, not knowing if there are data quality issues, that those are actually not the most priority provinces. And then also this causes programmatic distrust because you focus on your efforts and provide resources to certain facilities. You have stockouts here, you have oversupply here, and those are some of the implications. Next slide, please. So some of the confounding factors include population denominators from outdated census, data capture challenges when you have missing facility reports, submissions, manual errors, because most of it is manually entered. And that's why we've been trying also to try to digitize data as much as possible, even though there is a saying that it might not, that human element still is there, but it tends to minimize the errors. Then you have health system constraints, shortages of staffs, capacity, both in numbers, supervision, and also the quality of the staff we have. And then we talk about contextual realities like migration. Next slide, please. So in terms of the approaches and solutions that we've worked on, data cleaning and triangulation, usually you try to clean your data, break it down into, disaggregate it to subcomponents. And then sometimes you also try to triangulate looking at so you look at routine data reporting, you look at surveys that have been compiled, you look at previous data just to triangulate and make sure that whatever you are seeing makes sense. Digital systems and automation, that is what I just talked about. Capacity building, particularly making sure that the content of capacity building, both increase in terms of numbers and the training is really impactful, not just a training for training's sake. Collaborative review, and we also need the leadership of the government, the MOH, as well as donor and partner support as critical enablers. Next slide, please. So, in conclusion, the quality of our data fundamentally shapes the quality of our decisions. When we have poor quality data, it doesn't just affect the numbers on the spreadsheet, but it undermines program planning, distorts coverage estimation, misguides resource allocation, erodes trust, and all that. As well as some actions like cleaning denominators, triangulating data can help. So I hope we'll be able to reflect more in terms of how we can strengthen data quality and what best practices. Feel free to share from learners from your own particular programs. Thank you so much. Over to you, Felix. Thank you.
Yeah, so thank you very much, Ibrahim. Good morning, good afternoon, good evening to all of you from wherever you may be. My name is Fred Osei-Sapum. I'm the immunization focal point in the WHO country office. So quickly, I'm going to take you through some data quality challenges in the identification, enriching zero-dose and under-immunized children in our various countries. Let me turn off the video to save the bandwidth. Next slide, please. Yeah, so I would like to begin by showing this, global picture. So from this chart, the number of zero-dose and under-vaccinated children reduced from 2000 to 2019. But then with the onset of the COVID-19 pandemic and the disruptions caused to health systems and the immunization system in particular, we saw a significant increase in the number of zero-dose in 2020 and 2021, as you can see on the slide. However, with the implementation of immunization recovery plans, and most importantly, the big catch-up initiative, the number of zero-dose has reduced. But then it is still below the pre-pandemic levels. If you look at where we were in 2019 and the performance in 2024, clearly we are far below the pre-pandemic level. Next slide. Yeah, so one of the aims of the Immunization Agenda 2030 is to reduce the number of zero-dose children by 50% by 2030. So the light blue bar at the far right corner of the chart is basically showing us our targets by 2030. And then the black line shows the minimum annual milestone that we need to achieve in order to stay within the targets of the immunization agenda. So in 2024, if you look at where the black line is and then the last blue bar, you would realize that the number of zero-dose children was about 1.4 million above the 2019 achievement, which happens to be our baseline, and about 4 million above the trajectory, which is the black line. So clearly, we are far off the targets of, meeting the immunization agenda target of halving the zero-dose children as of 2019. Next slide. So please pay attention to the bars under the chart. So the number of zero-dose and under-vaccinated children are disproportionately distributed, with low-income and lower-middle-income countries having the largest. And if you do a quick mathematics, you would realize that within low-income and upper-middle-income countries, we contributed to about 14.8 million of the total zero-dose children out of 18.7 million zero-dose children. Yeah, and if you look at the chart above, you would realize that in terms of the GPT-3 coverage, lower-income countries have recorded a significant drop from 77% in 2019 to 70% in 2024. So clearly, within the challenges, the number of zero-dose is also disproportionately distributed, with lower-income countries and lower-middle-income countries disproportionately affected. Next slide. So, colleagues, if we really want to identify these children and reduce the number of zero-dose by 50%, then we need more than just vaccines. We really need good quality data to guide us to where we really need to take action. And I'm very happy this presentation is coming after the presentation by Ibrahim, where he touched on the key areas that could affect our data quality, the outliers, the missing data, the denominator challenges, and data that is really not consistent, especially if you look at Penta 1, Penta 2, Penta 3 performance. So in the previous slide, I gave a global view of zero-dose and under-vaccinated children. But country-level data is required to enable us appreciate the magnitude of the problem and also to know who are being missed, where they are being missed, why they are being missed. Once we're able to answer these questions, then we are setting ourselves on a very good path to reaching these children. So clearly, if our data is unreliable, it will definitely undermine our efforts to reach zero-dose children. Next slide. So now let's look at how data quality actually hinders our efforts to identify and vaccinate zero-dose and under-vaccinated children. So inaccurate denominator really undermines the foundation for identifying zero-dose and under-vaccinated children. And this in itself distorts our planning, resource mobilization, and even if you want to conduct equity analysis and your denominator is not accurate, you stand to start on the wrong foot. And this obviously makes it difficult to determine the magnitude of the unreached population. Directly related to the first point I raised is the issue of inaccurate numerator. So if you overreport or underreport the number of children that has been vaccinated in your catchment area, it will obviously skew the calculation of your coverage rates. So it won't give you a better appreciation of where you are and the actions you need to take. Now, without detailed subnational data, identifying underserved areas or population groups is difficult, which in itself will affect our ability to locate zero-dose and under-vaccinated children. In most of our countries, we have fragmented data systems. Some are combining manual and electronic systems, and there's also limited digital literacy among health workers, especially in low and middle income countries. And this obviously affects our ability to integrate these systems and also utilize the data that the systems are churning out. We also seem to have disconnected systems, as I've already talked about, and with low digital literacy, we are bound to make errors, even in the data entry, its analysis, and then retrieval. So I'm happy Ibrahim actually touched on some of the solutions we could use to improve the quality of our data. Next slide. Yeah, so to help improve the accuracy of our denominator, it is recommended that we conduct regular community head counts with local leaders to validate population data. We could do that by zoning bigger communities into smaller units just to facilitate such head counts. We could also leverage digital tools, which could even help us identify new communities as well as migrating populations to estimate our target population. With regards to the numerator, we need to use standardized recording and reporting tools in all facilities. In some countries, when you enter some countries, you realize they have different data recording and reporting tools. It's high time we get all these tools standardized, because this will ensure complete data is collected both from public and private facilities. So if you really want to have a complete data, we are not looking at only public facilities, but we must collect data from both public and private facilities. And we could also conduct periodic coverage surveys as well as equity surveys to validate the administrative performance. For data triangulation, of course, Ibrahim touched on this a bit. Yeah, we can also triangulate information from multiple sources, such as data from our health facility records, data from coverage surveys that have been conducted, and even our vaccine stock reports. Because as we triangulate, it will help us identify discrepancies in our data. So, for example, if a facility is reporting very high numbers of children vaccinated, but then the stock levels show fewer vaccines were used, you could quickly flag this and investigate. Additionally, we can even analyze the locations of confirmed cases of vaccine-preventable diseases, and then verify whether those locations are actually included in our micro plans. A case in point is in 2021, where Ghana reported an outbreak of yellow fever in one of our regions. During the investigation, we noted that the cases actually originated from a nomadic community that was unknown to health authorities, and none of the residents in that community had received any vaccine. So following this discovery, the community was therefore included in the district micro plan, and to enable us track such communities, Ghana began using spatial data and remote sensing technology to identify and map new settlements as they come up. So as you do this, you are able to capture every settlement, every community in your micro plan, and then you make sure vaccines are extended to them. Next slide. Yeah, so using data collection systems that actually capture granular data improves our ability to identify underserved populations. This approach will actually shift the focus from just viewing data from a country, a region, or a district to actually pinpointing the exact location where zero-dose or maize children may be coming from. For instance, instead of merely reporting that, let's say District A has about 1,000 zero-dose children, if you have a granular data collection system, you can actually identify the specific communities those children are coming from. And if you're able to do this, our health workers will no longer need to waste resources combing through an entire district, an entire region to search for zero-dose children. Your data will actually direct you to exactly those communities where we have the highest number or highest concentration of maize children. And lastly, countries with national identification. Please, can you go back to the previous slide? Yeah, so countries with national identification numbers and are also privileged to be using electronic data management systems, such as the DHIS2, could actually leverage these systems and deploy individual vaccination registry that can actually track vaccination records over time. And this will obviously help track every child and then establish whether they are zero-dose or they've received partial vaccinations or otherwise. Next slide. Yeah, so in conclusion, I believe we all appreciate very well that we are not doing very well if we really want to meet the reduce zero-dose children by 50% by 2030. And from the presentation, clearly low-income countries and lower middle-income countries lag significantly behind. And this is a clear demonstration of the inequities we talk about when it comes to the delivery of immunization services. But then because the data quality is not optimal, because the data quality is poor, we are unable to effectively target zero-dose and under-immunized population. So once we begin to have reliable, granular data, we will be able to identify where they are and then reach out to them. So it's important we use easy-to-use methods like the head count. We triangulate data from various sources and also invest in our digital tools in order to make sure we are able to reach out to zero-dose children and get them vaccinated. So thank you for your time. We now pass over to the next presenter.
Thank you, Fred, and thank you, Ibrahim, for giving such a wonderful and comprehensive background information on this very important topic. So my name is Aang Choos. I'm leading the work on health information system strengthening in WHO, HQ in Geneva in the data analytic and digital department. That's a new department. One of the key area of work that I have been very much engaged in countries and with partners is on two areas that both Ibrahim and Fred has mentioned a lot in the presentations, which is the routine data and the data quality. So I'm just give quite a broader overview of the role of the data quality and how does it drive the impacts. But then when Daniel discussed with me on this very important webinar, I also, with all what is going on with the data, with the work on immunization, as well with the funding landscape, I also think that, apart from we keep preaching about data qualities and how important it is, but then let's look at it from the user perspective. Until the desired impacts demand the data quality, the good data that is used for its purpose, we will continue to do all of this. And those challenges that Ibrahim and Fred mentioned, it has been going on for a long time. Next, please. Just a quick, I've just summarized my homework when we in preparation for this presentation, and I just look at the digital health strategy in Gavi for immunizations, the visions and the priorities. In order to achieve all of this, it requires a complex data and digital structure. And it's really nice to hear both the previous presenter talk about different data systems. We need to look at the combinations and the sharing data across routine community data system, reporting system. We also need to look at the population-based surveys, the census, the CRVS, as well as a lot of ongoing work on behavior. And now with the new eras of misinformation and disinformation, all of that have impacts on how we target and how we plan the work on immunization, specifically on zero dose. And then with that, and especially with digital, we will need to look at human and infrastructure capacity, look at investment. And one of the things that we also need to highlight is the commitment from the governments. We talk a lot about the needs from the donors and the international, the partner perspective, but this also have to come from the governments in order to have a strong commitment that push for the data quality. Next, please. And the next one, I'll just skip this one. Next slide. No, the one before this. Oh, sorry, the one after this. Next. Yeah. So this one here is, I'm not talking about the actual number in the slide, but what I look at here is the different purposes of how data is used by different target, by different group, by different purpose, and how does it influence and how does it determine how good the data quality is and how we can build the trust. And Ibrahim mentioned what is data quality and what consisted and considered as a good data quality. Regardless of whatever we use, the data quality will always need to be considered that include these 7 elements as something that we need constantly think about when we check if its quality data is good enough. Next slide, please. And with that, we need to look at that and see how good is good enough and what is it for. And by throwing, I'm just looking at here all different level of the data use. When we collect the data, either it is immunization registry records or whether it's aggregate data that is still happening in many low-income countries where registries is not happening yet. Regardless of wherever that is, who is using the data is also as important as how and who collects the data and who's as the subject of the data collections. In WHO, we have this 3 billion target that was announced a few years back. And the way we look at that is we look at it from the percentage, the coverage. But then when we go further, the further we go down, and I think it's very similar to micro-planning in immunization, the further we go down to the community, to the villages, to the hamlets, to the cluster population, the more we need to look at it from a population count perspective. Therefore, this is very important. And I'm so glad that both Fred and Ibrahim mentioned the denominator. This is something that it's been constantly back and forth, especially for immunization. When you report the national coverage versus when we look at the coverage in the community, which denominator, how we use it, what is it for, what is compatible, what is not, and then look at the 7 elements or attributes into the data quality to see how do you count it as consistency. All of that is a matter that we need to constantly think about and always keep in mind that who is demand the quality and what's the quality of the data and what the data that is for purpose, which purpose. And I think for that, it's really helped in terms of not going into too much into the details, because sometimes I'm just giving an example that when I was working in the country, this is a constant discussion of 82.5% coverage for measles is good enough or 82.3 is good enough. It doesn't matter because it's still below the standard of 95% threshold. So forget about that. It's maintaining it to see where are the lowest, where are the better, and invest and put more efforts in the lower rather than to argue about whether it's 0.5% different. And I think this is a key point of this slide. Next, please. So what we've done in WHO, in the past years, we have done developed a series together with Global Fund, with Gavi's and other partners on the data quality assurance toolkits. It's that with the attribute to the data quality, but then it also look at what is required in terms of measurements in an assessment for the data quality that collected at the facility level, and then from the system perspective, what else is needed to look into that, as well as now to look at the data quality and some of the tools for it at the community level. But 2 years ago, we had a consultation with multiple partners where we discussed and say, is that good enough? Because data quality toolkit is very much of assessing the data quality. But between the assessment, what can be done and what else can be added to make the data quality assurance is something that is comprehensive. And with that, we have added on other factors such as where and how would be the best. What about the data quality assurance when we conduct the population-based survey? What about data quality assurance when we use a GIS spatial data, when we do the data triangulations? What else can be done that we can say that, okay, we trust the data so that we can move forward with data triangulation, we can move forward with the estimates. So all of that is part of what we are discussing, and we are working on that at the moment to finalize the documents. And then on top of that, we are talking about digitals, and I'm so glad that the HIS2 has been mentioned in a couple of the presentation earlier. And half of the 40 plus countries that use the HIS, we have worked together with the University of Oslo and the HIS network to translate all of these toolkits and measurements into as a part of the standard data quality assurance that should be included from the beginning when we configure the DHIS2. And this is something that I think we need to look at the country, because the previous presentation, I didn't see that either. Instead of looking at the data that recorded, we need to look at the data quality from every single steps on the way of the data cycle. Start with definitions of the indicators. Start with definition of the denominators and numerator. And what is it for? And then how does it build in the data collections? Who is measuring it? How we can collect it? How we can change it? Every single potential attributes in the data quality has been included in the tool. So it should be built in as if the outlier should be spotted before it's entered into the reports. The differences in when they enter the data, the outlier in even enter the raw data versus the consistency, the consistency within the survey. So all of that has been built in, and I don't want to spend too much time on that, but I would be happy to share with you the resource for this. And it is available in the HIS. This is about how we can work together and then make it work. And then on top of that, with the other programs, and we will practice, and this is different program, but it should be the same kind of practice that can be also implemented, which is the monthly or the quarterly data quality review. And this is what we build on and say, before we move forward, before we conduct any micro plannings or quarterly planning, the data quality need to be checked. And then in order to do this, the immunization program is not enough. We need to bring in other planning sector part of the ministry and other partners, whoever are operating in the areas. We need to have it as a part of the data governance standards for who is responsible for the data quality, who's responsible for requesting investment and support, who is responsible for training the participants. So all of this is part of the data quality assurance that we need to look at from the data system perspective. Next, please. So we have we are conducting now the second round of the global health information system assessment. In the first round, which is done in 2019. And this is a global, as we see, and whatever we say about data quality, the completeness is really important. We see that only 50% of primary health care actually contribute the data into the national data system. Now that go back into the question of how are we assessing the quality of the national reports if only 50% of the primary health care actually contribute to the national reports. Now that data has increased. We are collecting the data, and you say in 2020 it's 67%. And then the private sector, Fred mentioned that it's important to include private sector, and immunization private sector plays a really big role in that. Not all the countries that have a private sector as part of the national reporting. So how are they going to account for that? How does it fit in between the immunization program reports and the national reports? How do we communicate that and make sure that our data is consistent regardless of where the source is coming from? And then the use of the patients is still very low. So how are we going to combine that and make sure that all of this important part of the data collection and data use system to be consistent, and then the immunization can benefit from the national system development strengthening and vice versa. And then one more point that we also found in the challenging is the capacity. So Fred mentioned the capacity. We train a lot of people to collect the data, but also we need to train them how to use the data. Only when they look at the data themselves and see that what they have done and achieved at the facility level, then the data quality will be improved. So lots of it going on. We need more investment and more funding on the data use and the demanding for the data quality. And then only that we would be able to strengthen the data quality and have it as a part of the key factor to drive the impact. Next, please. So this is a few key message that that is something that ongoing, and it has been going on for a long time. But I think I just learned this quote when I was searching around the website. The data quality begins and ends. It's not at the analytic team. It begins when we design the data, and it ends when we use the data. And it involves everybody that is part of this journey from the beginning. So with that, thank you very much. I'll pass it on to Daniel.
Thank you so much, Anne. And it's really exciting, interesting to see a lot of questions already coming up. I think there is a profound statement you made saying, the data doesn't just, it starts from collecting the data, but ends at using the data, which is really critical. And I will link this to, your statement around a combination of solutions are available, but do the government and users really demand for quality data? I think that's the bane of the whole of the issues that we have. it's clear to see that the implications are far-reaching, and many thanks to Ibrahim and Fred for really pointing that out. We are also really encouraged to see that there are actions that can be taken, from using simple approaches like harmonization of data tools through to using GIS to identify missed or perpetually missed populations, but also trying to triangulate the data to understand clearly, are we having just data collection issues, or are we can we relate these to denominators, or is it so much more than that? And I'm happy to also see a lot of colleagues who are also sharing other confounding factors like workload and incongruence between data collection and data summary tools in the chat. And these live examples really enrich the conversation that we are having right now, and I'm happy to see this. So I think we would now open the floor to see those who have questions besides what have been written in the chat to ask. I will take a look at what we have collated to see if we can have a round of questions, but I just want to give opportunity to those who might want to speak by show of hands while we collate questions that we have had in the chat for answer by our panelists and speakers live. Okay, I would quickly go to a direct question to Ibrahim. There was a question in the chat by Sonam, who really wanted to understand the denominator issue. We understand the extent to which denominator could affect programming, from planning to calculation of coverage and all of that. But we really want you to unbundle this issue of denominator. Is it something that can really be solved? Are there alternatives? Are there programmatic approaches to actually addressing these denominator issues?
Thank you, Daniel. Thank you, colleagues. I think this is a very interesting question, and I see a lot of interesting questions also in the chat. So the denominator, just to clarify, it basically describes the target children or people you're trying to reach to your vaccines, right? And as we say, except in countries where they have robust systems, we usually rely on fairly old data, some of it being census data that was way back more than 10 years or even some 40 years. We've seen countries that use data, census done in 1970 something. And the issue is if, for instance, with an outdated denominator or target population data, you're trying to plan for a particular district, the numbers are usually off. They don't reflect the current reality, right? Because in between you have migration, the growth rates will have changed. You probably have displacement, you have change in demographic patterns, the entire things have changed. And it's whatever you're having is most likely not truly reflective of the current status. And that will now impact because when you calculate your coverage, you rely on your denominator to compute what is the vaccination coverage in percentage, then use that to do your dropout rates. You do that and then based on that, you can now classify. When we look at the red rec strategy, you classify whether this has access issue or utilization issue. So if foundationally you have the denominator is flawed, then your coverage are flawed, the categorization is going to be flawed, then the districts that you're going to be targeting for interventions probably are not the most underserved districts. In terms of approaches, there has been several approaches. It may not be completely solved, but there are approaches that colleagues, stakeholders in the field have been trying to use. One has been triangulation, looking at different sources of denominator population, looking beyond just the census, but looking at where there are recent surveys. You can look at that to try to improve the accuracy of data you have. There's more recently, we have geo-enabled or geo-tagged population estimates. Those are also helping to give a fairly additional perspective in terms of what population estimates you could use. Some communities in some countries where I've worked in, they actually do a kind of enumeration. They track, they try to do a kind of mini household counting, head counting, also use the birth rates and all that. But that might not be feasible in very large countries. But that could help because it helps to give you or rejig your population estimates that you can use as part of the coverage. But it's very important to look at all those dynamics, look at the different perspective, consider your surveys, the DHS, the mix you have, any immunization coverage surveys, any polio load quality assurance, LQS, or RCS, rapid convenient as all this can help you to guide you in terms of deciding what is the near accurate denominator because it's very important. Once you have wrong denominator, then foundation is off, and then everything you're likely going to get things that are not depicting the most marginalized populations. Let me stop here, Daniel. Thank you.
Many thanks, Ibrahim. At least we have approaches, which is good. I think the next point will be for colleagues on the call to find which of these approaches or combination of approaches will be best suited for their own context. But before I let you go, Ibrahim, there is a question on the definition of zero dose. So, what exactly is zero dose? How do we define zero dose? And how does the misclassification of zero dose really affect the program?
Great question. And this has been a recurring question for we, the immunization stakeholders. But we have a clear definition. Maybe it's the assimilation that is still slow. We said zero-dose children are children that have missed their vaccines. They haven't received any vaccine. But programmatically, we use the first dose of DPT-containing vaccine, which is Penta, in a lot of cases, to say children that have not received the first dose of a DPT-containing vaccine or Penta out of your total target denominator are classified as zero dose. Why is that important? We've seen from different evidence that zero dose not only depicts or defines vaccination deprivation, but looks at other multiple deprivation. There are cross-cutting deprivations. And usually that is where you have the clusters of deprived communities and populations. You likely have the outbreaks coming up from there. You likely have all sorts of things are there. And it gives you a good approach to an entry point to basically have some kind of integrated PHC and service delivery perspective. Usually there has been multiple zero dose uses. I mean, some say zero dose polio, zero dose measles. Basically, they're just talking about the same thing. But globally, when we talk in terms of immunization language in this era, we're talking about non-receipt of DPT, first dose of DPT containing vaccine, and we use it programmatically to define areas to prioritize in immunization, including micro-planning, resource allocation, and other things. Thank you. Over to Daniel. Did I miss any part of the question?
Thank you so much, Ibrahim. That's very clear. I think the programmatic definition is clear. And once you have that as the benchmark, if they have not received the first dose of DPT, then or DPT containing vaccine, then that should be classified as zero dose. I'll come to you quickly, Fred. You did mention leveraging some digital solutions in Ghana, and we are happy to learn from Ghana with the impressive coverage Ghana is recording. We want to know specifically how this use of these tools, in the context of digital literacy and the workload that health workers are facing. What considerations did the Ghana EPI team keep in mind when leveraging digital platforms and solutions? We feel that your insight will be very helpful to colleagues on this call as they also plan to leverage digital tools to identify and reach both zero dose and under-immunized children.
Yeah, so thank you very much, Daniel. So I did indicate that Ghana is indeed leveraging on a number of digital tools in order to improve the quality of the work we do. And I actually gave an example where we miss out on a community, but unfortunately for us, yellow fever found that community for us. And that actually brought to bear the need to actually employ additional tools, including digital tools, to enable us identify, track, and get everyone vaccinated. Yeah, so the use of spatial data and remote sensing technology is not countrywide, but then we identified areas where we really need to deploy these technologies because those areas actually do have these nomads. And you know, the nomads are a migrating population, so it's difficult to track and nail them to a particular location. They keep moving. So if you don't track them, you cannot really get them properly tracked and vaccinated. Yeah, so when we started deploying this technology, it was more like identifying where we are likely to miss children, get people trained, give them the requisite tools so they could use those tools to identify such children, and then the system will get them vaccinated. So currently, remote sensing technology has been deployed in the northern part as well as some districts within the middle part of the country. Within the southern part, not much is being done in that respect because we think that we don't have a lot of migrating populations. And of course, with the challenges we have in the Sahel region, we have a lot of influx from the Sahel area coming in or moving into Ghana. And I mean, most of these people are also nomads. They move from one place to the other. So this technology is really helping us identify them and get them vaccinated. So like I said, it is not nationwide, but it's being deployed to where we really want to get these invisible children identified and vaccinated. Over to you, Daniel.
Thank you so much, Fred. I think what is clear is the problem statement should determine the type of digital solution that should be leveraged, and that is very clear for us to have, more precise and effective solutions. Thank you so much for sharing, that experience from Ghana. So, colleagues, there are many tools, there are many solutions, but the problem statement should determine the type of solutions that should be leveraged. I think that is one, key take home from this call. And I will come to you, Anne. What should governments be thinking when they are when they are planning interventions to address data quality, especially keeping in mind that, we need to think of sustainability post-donor support, So we have donors for a while, and we have partners, both technical and financial, but what should government keep, front and center of their mind when planning data quality interventions that are sustainable? Over to you.
Thanks, Daniel. I think it's back to the demand and the use of the data. Until the government actually use the data, and the importance of having disaggregated data or granular data so that we would be able to identify area, but then also able to zoom down as a micro level as much as possible. The nomad community is one, the community where it's very remote, the community where anti-vax happens. All of that is micro data. But we need to identify where the priority is, and that is the data use. The data use and the demand, that would strengthen the data quality. That's one. Secondly, it is important to identify and to support the governments and also to demand the governments of their roles in the whole data system and data structure. Who is responsible for what? The use of data normally go with the program. So immunization, regardless of wherever you sit in the health system and the health service, you want data and you are responsible for the data quality. but that also your responsibility to build the trust of your data to the governments. And by doing what? By having a regular communication, by having a feedback mechanism, by build the capacity. And the capacity building is not just a program, it goes into the ministry, go into the government. And so is the regulations, the policy on who's how often we can check who's responsible for responding to gaps in ensuring data quality, who is responsible for setting up the data collection system, linking ID for immunization with ID for healthcare and government ID, who is responsible for linking that with the CRVS. All of that is the role of the government. And we need to make it as a part of the strategy. And that also the communications from the global community is also to say, we will support the government when they are taking the leadership and the ownership of the health sector and of specific programs. And for zero dose, different country will have different targets. But if we say zero dose is really important, and we will support the country to build the capacity to identify that and have data at micro level enough to be able to point out, who is going to provide the service to whom and where, and set the target. The target has to be very close and as detailed as possible and granular as possible. But it comes from a very clear understanding structure of the data and where the service is provided.
Many thanks. And it's very clear. One, we need clear roles and responsibilities, who is doing what. And then also, it's not just enough to collect the data, we need to use the data, because if we don't use the data, then of course, we can't know, if there are gaps or data quality issues in the data. Data use is not an action that is left for immunization managers at national level alone. Data use starts from the point of data collection. So even at the facility level, the health worker should be able to have those, data triangulation, data comparison, and so on, to use the data at that level of collection, and then, translate to data use even at the global level. I want to thank everyone for joining. It's been a very rich and insightful discussions, both live and in the chat. I'm really, really excited to see, how engaging the chat has been. This is the first of a 4-part series of webinars. So looking forward to catching up with most of you in the other following sessions. And I would just want to leave us with one line, which is to say, keep up the good work in where you are. This is the responsibility of everyone, and keep turning data into impactful insights. I will hand over now to Elizabeth for some few announcements. Over to you, Elizabeth.
Wonderful. Well, thank you so much. Really appreciate everyone joining us today, and special thanks to our wonderful panelist and moderator for leading such a rich and thought-provoking discussion. And we really appreciate the audience's engagement and participation. It's really been fantastic to see everyone's active involvement. So as a follow-up, we're excited to share 4 new knowledge products related to today's topic and other innovations in technology and digital health. And so these resources on your screen will be available on Gavi's website and through our Boost Learning group. And again, we'll also be circulating them via email in the coming days. On the next slide, we also encourage you to visit and join our Boost community, which is a virtual platform designed to help immunization professionals like yourself connect with peers and experts and strengthen skills and capacity. And then within Boost, you'll find our zero-dose lessons in action learning group, where we will be storing today's slides, the session recordings, and any related resources that you saw in the chat today. Before you leave, we do kindly ask that you take just a quick 2-minute post-session survey to share your thoughts on today's session. The survey will pop up automatically when you exit the webinar. And your feedback is really valuable and will help to shape future sessions, like Daniel mentioned in the series, which will continue in September and October. And we'll be sharing more details about those forthcoming sessions very soon. So thanks again for being part of this important conversation. We very much look forward to continuing the dialogue and wish you a wonderful day ahead. So thank you, everyone.
Thank you.
Thank you.
Bye.
Great day. Thanks, everyone.
Thanks.